Our first case this morning is a 75-year-old male, Caucasian ancestry, with a family history of pancreatic cancer on the maternal side. This patient has a history of no alcohol or smoking, but in the last month he's presented to us with a 6-kilogram weight loss. And upon performing cancer antigen analysis, he had a significant elevation. So we performed a CT scan, which showed a thickening of the gallbladder and the common bile duct wall. PET scan showed an increased uptake of multiple abdominal and mediastinal lymph nodes. And the MRCP showed a gallbladder, cystic duct, and common bile duct wall thickening downstream to the papilla. We also observed intrahepatic biliary duct dilation as well as multiple pathological abdominal lymph nodes. Today, our patient will be undergoing an ultrasound endoscopy with ERCP, confocal, and biliary stenting. These are the images from the previous MRCP. And again, as I said, today this patient will be undergoing an EUSP with ERCP, confocal, endomicroscopy, and biliary stenting. The procedure today will be performed by Dr. Giovannini and Dr. Testoni.
We start by a challenging case because this is a combined procedure with a US and the RCP. You know that the place of US in the cholangiocarcinoma is not very well defined in the literature. I just want to stress you that the results of the US FNA for the distal mass for cholangiocarcinoma are the same accuracy than the biopsy for pancreatic masses. And the goal of the US is to find some contraindication for the surgery as the lymph node staging, which is more precise, the sign of peritoneal carcinomatosis, like a small amount of ascites, and the involvement of the hepatic artery. Okay, I'll start the examination. I use the Ascendus machine and the EG38 UTK. This is the head of the pancreas with the portal vein. And here you have the hepatic artery. Here you see very well with the Doppler, and you see that the bile duct is just here. It's very thin here. It's very thin in the head of the pancreas. And the technique to see the hilum is to pull back the scope and to do a anti-clockwise rotation. And here you see the hilum will appear in this area. Here you see the gallbladder probably with a very thick wall. And if I continue to turn, you see a small amount of ascites here, which is a bad sign. Here I'm in the hilum. The hilum is here. This is probably the dilated bile duct. You see, this is the dilated bile duct. And in this position, you are sure that the patient has a stenosis, is a type 1 of bismuth, because you see the bile duct this is the common hepatic duct. And this is a very good, this is very important to know for the RCP, because you see that in this case, one stent will be enough.
Just is sufficient, yes.
Okay. And here you see that the bile duct will be occluded by the tumor here. You see the tumor here, definitively. Here you see this is the stenosis, and this is the wall of the bile duct. And here you have the tumor. This is the hepatic artery. You see that the hepatic artery here is very close to the tumor. And if I continue to turn here, there is probably here an involvement of the tumor. This is the cholangiocarcinoma is very close to the hepatic artery. Okay. And here you see the mass. Huh? And the mass is here, very close to the hepatic artery. Okay, this is the second contraindication with the small amount of ascites. And now, if I pull back my scope, I will go to do the node staging in the celiac area. This is the left lobe of the liver with a huge dilatation of the duct. And if I turn my probe, here you see a lot of nodes. Here, if I increase the size here, and you see with the elastography, these nodes are malignant. There is a very blue, very hard, and I can perform now very quickly a cytology on this node, and this is probably the third contraindication for surgery. And this patient should be treated by stenting and after chemotherapy using a protocol with cisplatinum or oxaliplatin and Gemzar, because this is the standard treatment for advanced and metastatic cholangiocarcinoma. Okay, if you can give me a needle, I will use for this biopsy the Procore needle, the 25 Procore needle, because I don't need histology, I need only a good cytology. I can take this node, for example. Okay, this is the Cook needle. And you see, this is the main advantage of the US and all the capability of the US in cholangiocarcinoma. This is not very well known, and in some okay, I need some authors said that there is no indication.
Mark, do you ever sample ascites at all?
There is some ascites, yes. I show you the.
Yes. Do you ever sample ascites?
No, I think in this case, I think it's not necessary, because I need that somebody maintain the scope in a good position, because we have a node here, and the node is. I think it's okay, perfect. You see now I block the wheel of my scope. I have the help of one nurse to maintain the scope in a good position. And now I'll try to target this node. You see, it seems very hard. Okay, now I'm in with just to be sure that I see the tip of the needle. Okay, now you can remove the stylet, please. No, the syringe. Remove everything, remove. Give me the syringe, the vacuum. Now this is the old technique. Okay, and now you open. And okay, I perform a back and forth movement inside the node. I change the position. This is the fanning technique. You see there is a randomized study. This randomized study by Shyam Varadajulu show that the fanning technique is superior to the standard technique using only one passage inside in the same direction. You see, I move the passage of the needle with my small wheel or using the elevator. You see, like this, with the big wheel, and the elevator. You see, I change here the position of the needle. And I think now it's enough, and I will see the results. And we have the pathologist in the room. Okay, if you have some question, I think this procedure is finished.
So Professor Doglioni, who is the chief of our pathologist department, will show us the results. Claudio?
And in the field, microscopic field, you can see lymphocytes, and here a single atypical epithelial cells, but in the other part of the smear there are many more atypical structure, looks like papillary, And this is a glandular structure, so this is a pathological lymph node metastatic from adenocarcinoma. This is a very easy picture. Okay?
Thank you for your quick and precise diagnosis. This is fantastic. Diagnosis in 10 minutes. Super. Thank you so much for working up the specimen immediately.
Have already cannulated the papilla. We use CO2 for long-lasting procedure. Papilla looks normal. We try to start with Triton because we have to manage the contrast injection, the guide wire. But we have some difficulty starting with the cannulation because the papilla was moving. You can see there is little bulging about the papilla, so we change with the cannulotome. The cannulation was very easy and rapid and quick. And then we achieved the biliary system.
And you use the new wire from Cook, no?
Yes.
It's the Acrobat wire.
Yes, we use the Acrobat because the Acrobat is a very thin type. And since we know that there were very tight strictures, we prefer to use this kind of guide wire. And then we achieved the intrahepatic biliary system. We did the contrast injection. Perché non va? Dov'è? Vediamo di là. Allora, potevamo cambiare la... Vedo di là io. Ok.
I hope that there will be a type 1, huh? That
Yes,
I show you
type 1.
with the US. Yes.
We start with a little cut by using herbe endocut. I believe that is sufficient, just a little bit, okay, just to move. Now we leave inside the guide wire, we remove the Triton.
And you will proceed by the confocal imaging of the stenosis.
Yes.
Okay, if you can focus on the probe. I'm sorry. Here you see this is the cholangioflex probe. It's 0.9 millimeter. We use a double channel catheter, one channel for the probe and one channel for the wire. And this is the technique, the simple technique to use the confocal microscopy. Of course, we need to inject before the fluorescein. Okay.
We have injected fluorescein or not
Now
yet?
you can inject. You can
You can inject fluorescein
because
intravenously.
we should wait. We should wait 30 seconds, 1 minute, that the fluorescein will.
We have had a good experience with confocal and the microscope by defining the exact place of the changes within the duct.
Yeah,
so we have a targeted brushing in the worst areas, worst segment.
We just finished a very interesting study. This study will be presented during the next DDW. The study is named the Focus study, and this study evaluated the place in the therapeutic decision making of the confocal microscopy. They compare the results of the RCP finding plus the confocal microscopy, and the RCP finding plus the PCLE and plus the biopsy, the brush cytology. And the PCLE increase of 37%, the accuracy and also the specificity in the indeterminate biliary structure. It was a patient with biliary structure with no visible mass in CT and or in MRCP.
Vediamo il filo guida dove un attimo. Ok, ce lo vede là. Now we are inserting the probe.
The catheter size is 8.5 French.
You can see here the probe.
Yeah, very nice.
Is entering the papilla. Now we move to the push the probe until this above.
And you see that the sphincterotomy is yellow. This is a good sign that the fluorescein is okay. You see, because you have cutting some small vessels, and fluorescein is coming out in the.
Okay, we
Okay, I
reach.
think you are in a good position
We're
now.
in a good position about the
You-
strictures, so we can start with
we can
confocal
start.
evaluation.
There is, this is. Okay.
Okay,
You
now
are
we
okay.
tiriamo
Now
indietro
here
il
you
probe, tiriamo indietro
here
il
you are
probe.
quite a normal the normal aspect of the
Tiriamo
bile
indietro.
duct, and here.
Il probe.
Do you
il
record
probe,
here
perché c'è un po'
the
fuori.
image? Okay. Can you put the probe? Here it was. No. Here you are inside.
Okay, we're inside.
Here, don't move. This is the good position of the probe. Okay. This is the good position. Here you have some normal area. No, push a little bit out. Yes. Don't move here. No. When you see this, this is the catheter. This is the normal image. Oh, okay. We will record the image. You are at the level of the stenosis.
No, we are
No, pull,
above, so we are
pull back the
removing. Vado avanti col filo guida però vediamo, ok?
Pull
Sì,
back
perché vado
the-
avanti col filo guida. Sì, ma io sto venendo indietro adesso.
pull back.
Ok? We adjust the level of the strictures.
Là, here.
Ok, now we
This
are
is,
perfect. Io tiro indietro tutto e le tengo fermo così, So I
Okay. This is inside the catheter.
fuori, più avanti, più avanti. No, vada avanti, vada fuori,
Inside the
spinga
catheter.
fuori il catetere.
Voilà.
Deve stare così. Adesso io vengo indietro, lei non lo tocchi più, vengo indietro con tutto io, tenga solo il filo guida.
Okay, if you stop the image, I will show you some pathologic image that we have.
One,
Now, here you see you have
Yes,
you have the so-called epithelium structure. You have it's difficult to see. There is no pointer. You have this epithelium structure with a finger-like projection. This is the image of. It's probably a papillomatosis with a malignant change here. Here again. Here you have a nice image here of this gland. The gland is abnormal in the bile duct. In the normal bile duct, you don't see the gland because the depth of penetration of this probe is around 40 micron, and you see always the chorion of the and not the mucosa. Mucosa is very thin in normal bile duct. When you see this aspect of gland, is always malignant change, is an adenocarcinoma. No? Here again, you have this so-called epithelium structure. And you see that this technique is you should record and step by step after to see the imaging. There is also other imaging here. Here you have the irregular vessels. You see with probably the black area. This is the black the malignant cells with the neovascularization. This is also a sign of malignancy. I think this is probably the. I learn a lot with my pathologist, with Madame Monge, who is in the room, in Paris.
Okay. Now we enter the strictures.
Okay,
We are inside the stricture now with the confocal probe.
Do you have Mark,
But you-
in the
you are-
room,
you are-
is there any
you
way
should
you have an
put-
arrow on the screen that you could
you are
demonstrate,
here.
or is
You are
there no
inside
arrow?
the
Yes.
This is the plastic.
Più avanti. Okay.
Okay, perfect. This is okay. Yes, I hear you.
Do you have do you
No,
have
you
a
are in
pointer
the-
that you
I don't
can
have the
show?
pointer. No, push out. Yes. Push out.
Più fuori. Vado avanti. Ecco.
Fuori, guarda, va bene. Questo è buono. Questo.
Yeah, we have very dark imaging.
No. No, you are into the catheter.
Allora, vengo ancora indietro.
Here you see some normal aspect. I will show you some normal aspect of the bile duct. this is the normal aspect of the bile duct. You see, you don't see gland, you don't see abnormal vessel. You see this black band, which are the fibroconnective tissue of the wall of the bile duct. And you see the difference with the here it's
Can I suggest tomorrow when you do the case discussions that you can bring a video and perhaps demonstrate in the room here.
Yes, and here you have
with the
also
pointer what you're looking at. That would be
also
I think
a
the
gland-
audience
a
would
gland
really appreciate
structure.
that. If that.
Can you see the imaging now? No. Eppure lo schermo.
okay. Okay.
What about this imaging, Mark? Normal?
This is not it's not normal, but this is difficult to. But you will have very nice image. You had a very nice image in the previous.
Alberto,
Okay, yes? Are you, I'm
you
waiting.
look enthusiastic.
No, we are trying to be within the strictures. We have some imaging disturbances. No, we use in the past. I am enthusiastic, but in this case, it's a little bit difficult to identify the lesions. Imaging is not perfect again. So we are moving the catheter and the probe, but now our catheter is we are outside, so the probe is completely outside from the catheter, but the imaging is not perfect now. Now we have a good imaging again. Venga indietro col cateterino. Venga indietro. So we remove again the confocal probe. Ragazzi, ma noi siamo fuori qua, We are outside, completely outside from the tritome, the catheter, but the imaging is not perfect, as was in the past time.
Here you see
Lascia la fila guida.
thick black band with an organization like a glandular organization, which is highly suspicious of malignancy, and these clumps, these black clumps, is quite typical of adenocarcinoma. This is never found in a benign stenosis. And I will show you also some other image of humps of malignant cells. Here you see the black, the black. You have a gray and very black cells. This is the aggregate of malignant cells. Here you have also like a triangle with malignant cells, which are black and larger than the inflammatory cells. Here again, and here you have a complete disorganization of the structure of the wall of the bile duct with neovascularization, and here again with this black humps of malignant cells, with also the you see on the left of the image you have the lake of fluorescein. This is the vascular lake. And here also you have these images of cancer with these black clumps, which are typical of malignancy here.
The brushing was adequate and the diagnosis was confirmed. So now we are inserting the stent, autospand metal stent, evolution 8 cm length long. Sì.
Fai vedere un attimo.
We remove the catheter. Just in 1 minute we insert the stent. The next minutes we are ready. We use a long 8 centimeter long stent, uncovered of course, because we reach the middle part of the common bile duct, so we close the cystic duct, but it seems to me that the cystic was already strictus. The brushing was positive, so we have no problem for further investigation. We don't need to do biopsy because we obtain a positive brushing, and then we place the stent, the evolution type hook. You know that it is a very easy handling of the stent. We can release the stent very easy. Now we reach the levels. Okay. Okay, we release the stent, start. Okay, we start to read the stent. The stent has a distal opening. We maintain the level of the stent in the biliary from the duodenum, so we have to retract a little bit when they display the stent. Now the stent is opening within the strictures. Okay, we are at the end of the procedure. Okay. The stent is perfectly open, and we close, we finish our procedure. Any question? We remove everything. We have the bleeding coming from the brushing, and we end up, we finish the procedure.
Now we move to Professor Doglioni to see the results of the brushing that Pier Alberto has performed in the common bile duct, just to see whether the confocal examination and the pathologist are agreeing on these pictures. Claudio?
Okay, again, this is a positive brushing, positive for malignant cells. And in the video you see a representative field in which there are normal cells and two malignant atypical glandular cells. So again, this is a quite easy pathological interpretation. Thanks.